Hello. Okay, so today I'm going to talk about multimodal imaging in mood disorders. So I'm going to talk a little bit about what are mood disorders and then about the neurobiology of depression and how we treat depression. And then how do we use imaging and what can imaging teach us about depression and treatment of depression? So first of all, what are mood disorders? So mood disorders broadly can be divided up into two categories. There are the depressive disorders, such as major depressive disorder, which is sort of a relapsing, remitting course where people have major depressive episodes. And then there are different other kinds of depressive illnesses as well. There are the hormonally mediated depression syndromes, such as postpartum depression and premenstrual dysphoric disorder. There's seasonal affective disorder, where the major depressive episodes tend to be timed seasonally, and several others. And the other broad category is the bipolar disorders. And these involve periods of elevated mood. So bipolar disorder type 1 would involve periods of mania interspersed with periods of depression. And then bipolar type 2 would be major depressive episodes interspersed with episodes of hypomania, which is a less severe form of mania, but still has elevated mood, reduced sleep, things like that. And then there's cyclothymia, which is episodes of elevated mood without the episodes of depressed mood as well. So major depressive disorder so the way we diagnose this is generally either the symptom of depressed mood or the symptom of anhedonia has to be present. And anhedonia is basically no longer finding pleasurable activities pleasurable. And then there are a host of other symptoms, and you only have to have a certain number of these. You don't have to have all of them. But you can have changes in sleep, either increased sleep or decreased sleep, changes in weight, either weight gain or weight loss, changes in activity. Some people have agitation, some people have psychomotor retardation. You can also have feelings of guilt or worthlessness. Patients often report problems with concentration. And there's also suicidal ideation or even suicidality, suicide attempts. The treatment is really empirical. We have a lot of drugs to treat depression, and none are terribly effective. Most drugs, a first-line drug will have around a 30% chance of eliciting a response. There was a really large study called the STAR-D study where they looked at kind of treatment algorithms with either augmentation or switching drugs in a very large, somewhat naturalistic sample. And what they found was it took 2 trials and 6 months of time to achieve a 50% remission in their patient sample, which is pretty poor. So a little bit about the neurobiology of depression and treatment and why it's so hard to treat. So when we think about the neurobiology of depression and we think about brain anatomy, there are really 2 core brain regions that come to mind. So the first is the subgenual cingulate cortex, or Brodmann area 25. So the cingulate cortex wraps around the corpus callosum, and this part right here that's nestled underneath the genu of the corpus callosum is called the subgenual anterior cingulate. And the other region that we associate with depression is the amygdala. And it's a subcortical area that's present even in animals that don't have the same convoluted cortex that humans have. And it's been known for a long time to be involved in emotional expression and processing of emotional stimuli. But beyond that, depression has been modeled in terms of symptom domains and what brain regions are involved in those symptom domains. It's been conceptualized as involving networks of neurotransmitter pathways in the brain. It's been complicated models have been formed by looking at wiring diagrams and structures that we know to be connected by physical connections. And it's been conceptualized in terms of functional networks from imaging studies that work together. And there have been a lot of different models put forward to cover depression. They're not terribly convergent onto a single model, and they all tend to be very complex, and nobody really knows yet what's the right one, or even if this is the right way of thinking about depression in the brain. There is one model that has come more to bear recently, which is called the triple network model, and more data seems to be convergent onto this model than any of the other previous models that have been put forth in the literature. So basically, the triple network model says that there are three primary brain regions. There are more than three brain networks in the brain, but these are the three primary ones that are really involved in various psychopathologies, not just depression. So the first is the default mode network, which by this point in the course, you guys probably know what that is. And it really involves interoceptive processing, self-referential, mental activity, and it's called the default mode network because it's thought to be what the brain is doing in its default state when it's not doing a goal-directed task. Then there's the central executive network, which is involved in goal-directed activity or any kind of activity that requires cognitive processing. And then finally, there's this third network called the salience network. Now, the salience network we know is involved in processing the relevance of stimuli, and it's also thought to be involved in a dynamic switching between the default mode network and the central executive network. And so it's been postulated that connectivity within these, and connectivity and abnormal activity within and between these networks is part of the pathology of depression. So how do we, a little bit back to the depression and how we treat it. So one of the original hypotheses for depression was monoamine dysfunction, or dysfunction in one of the monoaminergic neurotransmitter systems, such as norepinephrine, serotonin, or dopamine. And when the SSRIs came out in the 1980s, serotonin took a forefront as being the neurotransmitter most likely to be involved in depression. But that can't be the whole story, because we know that the SSRIs actually increase serotonin in the brain very rapidly, but the response, the antidepressant response to an SSRI takes on the order of 6 to 12 weeks for full effect. So the full story is definitely beyond just monoaminergic dysfunction. But nevertheless, all currently FDA-approved drugs target the monoaminergic system. And this is just a graph showing part of our problem with depression treatment right now. And this is the number of mechanistically distinct drugs in the 1950s and at present for depression, schizophrenia, and heart disease. And you can see between the 1950s and now, there's been a huge increase in the number of unique targets that we have for treating heart disease. However, with depression, since the 1950s, there's only been one new mechanistically distinct drug developed, and that's the class of SSRIs. So clearly there's a fundamental problem with CNS drug development right now. So an alternative treatment that our lab has been working on for many years is ketamine. So ketamine is an FDA-approved anesthetic. It's also a Schedule III controlled substance, and it is a drug of abuse. It's an NMDA receptor antagonist. It binds to the same site as PCP and has some of the same psychotomimetic or dissociative effects when given acutely. However, when a subanesthetic dose of ketamine is given to a depressed subject by IV infusion, subjects have a robust and rapid antidepressant response. It happens within hours to a day, and it lasts about 7 to 14 days. And because of this rapid onset and short-lived effect, while that makes it non-ideal for a ongoing treatment, it does help us study depression and its treatment and the antidepressant response, because we can do crossover studies. So we can do a study where we give someone a drug, wait a couple weeks, and then give them the placebo, or vice versa. And so ketamine ends up being a very good tool to be able to study rapid antidepressant effects. So how does ketamine work? The short answer is we aren't sure, but at this point, what's kind of thought to be the model for ketamine's action in the brain is that it blocks NMDA receptors, and it blocks them both on the excitatory glutamatergic neurons, but also on the GABAergic inhibitory neurons. So in blocking the inhibitory interneurons, that disinhibits the excitatory glutamatergic neuron and results in a glutamate burst in the synapse. Now, since the NMDA receptors are blocked, then that glutamate, that extra glutamate is taken up by the AMPA receptors, and it results in a cascade of downstream effects, including synthesis of BDNF and mTOR, and ultimately results in synaptic plasticity and things like increases in spine synapse number and function. But again, we know that's not the whole story, because not all NMDA antagonists elicit antidepressant responses. And recently, there was a study looking at the metabolites of ketamine, and it was found that one of the active metabolites, a hydroxynorketamine, actually does elicit an antidepressant response that's on par with what you see with ketamine, but it is not an NMDA antagonist. However, it does induce a gamma power response in animals, which is thought to be a marker for enhanced AMPA throughput. So the full mechanism of action of ketamine is still not fully understood, but it's believed to involve enhanced AMPA. So for the rest of this talk, I'm going to talk about the ways that imaging can inform studies of depression and studies of depression treatment, and I'm going to intersperse studies from the literature along with studies from one of our recent trials, which we call the ketamine mechanism of action study. So in this study, we took healthy and depressed subjects, and after a drug-free period of at least 2 weeks, they had a crossover trial where they either got infusions of ketamine or placebo, then after 2 weeks crossed over to the other condition. And at 5 different time points, at baseline, after each infusion, and then 10 days after each infusion, they did a whole battery of neuroimaging metrics. They did MEG, or magnetoencephalography. They did 3T MRI with a variety of modalities, and they did 7T MRI as well. So our clinical findings from that study were, again, in our depressed subjects, we saw this robust decrease in, so MADRS score is just a depression rating scale, and so we saw a large decrease in their depressive symptoms that actually, in this particular cohort, lasted out to about at least to day 11, and our subjects also saw an acute increase in dissociative symptoms that went away rapidly. Unexpectedly, in our healthy subjects, we actually saw a rapid increase in depressive symptoms, and these symptoms were significant out to day 1 and were primarily accounted for by symptoms in the domains of anhedonia and anxiety. Okay, so what can imaging teach us about depression and its treatment? How can we use imaging? We can find biomarkers that subdivide patients into distinct phenotypes. We can find biomarkers that can predict who will respond to a given intervention. And our hope would be that these markers would change in response to treatment and may display a dose-response relationship such that people who respond more will have the largest change in their biomarker. So that's the goal. And we can look at potential biomarkers in a variety of domains, and the ones I'm going to talk about today are brain structure, cognitive function and functional imaging, intrinsic connectivity or resting state functional connectivity, and then neurophysiology. So first of all, brain structure. From the literature, the most robust volumetric finding over the years has been changes in hippocampal volume. So the hippocampus is the structure right here. It's curved, and it's multiple layers of tissue folded in upon itself. It kind of looks like a seahorse, and hippocampus is actually the Greek word for seahorse. And on an MRI scan, it shows up as this region right here. And over many studies, the majority of studies have consistently found reductions in the hippocampus, and meta-analyses have showed that there's a moderate effect for reduced hippocampal size in major depressive disorder. So in our study, we've started looking at high-resolution hippocampal images at 7T. So this is a T2 star weighted image and you can see across in this axial image, you can see an axial cut through the hippocampus right here. And just for comparison's sake, so here's a T1 3T image with a sagittal slice through the hippocampus, and you can see the folding and the layers curving here, but it's difficult to make out. And then here's one of our 7T images where you can actually quite clearly see the folding in the hippocampus and this layer called the dentate gyrus where new neurons are actually formed. And we can start to do things looking at deformation morphometry, where we take a large group of these images and then deform them to a template and look at what areas correlate with clinical variables. And one of the things we found in our preliminary data, we haven't yet repeated this in our full data set, is we found some negative associations between parameters such as the length of the current episode and reduced volume in the subicular subfield of the hippocampus. And you'll remember from the beginning, one of the sort of cardinal regions that I talked about being involved in depression is the amygdala. So why has the hippocampus been studied so much more than the amygdala? And part of that is just for practical reasons. So this is just a coronal section through the brain. You can see the hippocampus. It's bordered on all sides by white matter, and it's very clear to delineate. Whereas the amygdala is much more difficult. It's much more difficult to ascertain the borders of the amygdala on MRI images. And even though there have been quite a few volumetric studies looking at the amygdala, they tend to be very inconsistent in how they define borders of the amygdala, and you end up having to make some decisions like making vertical cuts from one landmark to another to be able to form repeatable boundaries of the tissue. But because we have these scans at 7T, one of the things we're working on is using, again, something like deformation-based morphometry to find out if we can ascertain if there are volumetric differences within the amygdala. And you can also see, so the amygdala is composed of separate nuclei, and you can start to see on these 7T images that you can actually get a hint of what looks like might be individual nuclei within the amygdala being visible on these images. And this is not visible at all on a 3 Tesla MRI image. So that's subcortical areas, but what about the cortex? So there's a group called the Enigma Consortium that has been recruiting groups from all over the world to contribute data to look at brain structure and volumetrics and genetics. And they've recently developed working groups to look at separate patient groups. And because they've gotten data from such a large consortium of people, they've been able to do studies with pretty incredible numbers of subjects. So from the major depressive disorder work group, they looked at cortical volumes in about 2,100 depressed subjects and almost 8,000 healthy controls, and found some really focal areas of cortical thinning in the depressed subjects. And these line up nicely with temporal areas next to the hippocampus and amygdala, as well as dorsal cingulate and then anterior cingulate, particularly that subgenual anterior cingulate. They've also looked at bipolar disorder in about 2,400 bipolar subjects and 4,000 healthy controls, and found much more widespread deficits in cortical thickness as compared to the much more focal deficits of major depressive disorder. And it's really kind of unknown what the significance of this is in terms of the pathophysiology of the disease, but certainly bipolar disorder is much more difficult to treat than major depression. So when we think about looking at brain structure, we also think about looking at things with DTI. And using DTI in depression has been somewhat disappointing in terms of the study results. So this is a meta-analysis of about 11 studies that found some very focal areas of reduced fractional anisotropy in a few tracks. Intuitively, one would hope to see alterations along an entire tract connecting regions and not just focal areas. So it's still a bit unclear what deficits such as this mean physically. And a more recent study, a fairly large single study, looking at 130 depressed subjects, 98 of which were treatment naive, and 50 healthy controls, all medication-free, found no differences in diffuse and tensor metrics. So because looking at the whole brain has been somewhat disappointing, in our mechanism of action study, we decided to look more focally and think about regions to look at, or think about tracks to look at that connect regions that we're very interested in. So our primary target regions were the subgenual anterior cingulate cortex and the amygdala and the tracks connecting those regions. And because we have such good evidence that the hippocampal volume is reduced in depression, we included that as a secondary region, as well as thalamus, and there's also some evidence about thalamic tracts and thalamic volume in depression. So baseline imaging, this is from baseline imaging in 31 depressed subjects and 26 healthy controls. This was before they went on to any ketamine treatment. Found that overall there was a subtle reduction in fractional anisotropy and increases in mean diffusivity, both of which indicate that the white matter in these subjects, at least along these tracks, isn't as healthy in our depressed subjects as in our healthy subjects. And we actually did see this result quite clearly in the tract connecting the right amygdala and the subgenual anterior cingulate. And this is just a graphic, a slice through the brain, and these red ROIs here are amygdala, and this yellow blob here is our subgenual anterior cingulate ROI, and you can see these tracks that are connecting the amygdala and the subgenual cingulate. This image also includes the tracks from the hippocampus and the thalamus. That's what these are. But when we look at those tracks that were significantly different in between the right amygdala and the subgenual anterior cingulate and correlate those with subsequent treatment response to ketamine, we also find a nice correlation between fractional anisotropy and the percent change in MADRS score. And specifically, the subjects who had the lowest fractional anisotropy, so that would be the least healthy white matter, were the ones who had the greatest reduction in their antidepressant symptoms following ketamine. So quick recap. So from structural imaging, we've really seen volumetric alterations in limbic and anterior cingulate cortex areas, and this is also supported by evidence from cortical areas adjacent to the limbic system, and also some alterations in cortical limbic tracts. Okay, so the next topic then is cognitive function and functional imaging. So when we think about cognitive function and functional imaging in depression, we kind of think of it in terms of different domains. So the first domain, and probably the one that's most frequently studied, is affective processing. How do people process emotions? And there's a good deal of evidence that points towards a bias towards negative stimuli and away from positive stimuli in subjects with depression as compared to healthy subjects. There are also impairments in attention. We probe attention with things like dot probe tasks. There are alterations in working memory and executive function. And we look at things, use things that impose a cognitive load like in-back tasks or delayed matching tasks. And there's also reward processing that gets into domains of anhedonia, and those are frequently utilized tasks that involve winning money and looking to see how rewarding winning something is and how much effort subjects put into winning a reward. So there have been some good meta-analyses looking at emotion processing in depression. This one looked at 38 different studies. And overall, you see a hyperreactivity in dorsal cingulate and in the amygdala and insula here in response to negative stimuli as compared to positive stimuli or neutral stimuli. And you also see a reduced reactivity in the dorsolateral prefrontal cortex and the caudate, also to negative stimuli. So these are areas that would respond more strongly to positive stimuli than to negative stimuli. It's often difficult to do meta-analyses like this because all of these 38 studies, they didn't all use the same task designs, and so there are many ways to elicit emotional responses and many different kinds of emotional stimuli, and frequently they'll induce very different, they might activate the same areas, but induce very different patterns of response depending on parameters of the task. Another meta-analysis looking at 44 fMRI studies found very similar findings. Negative emotions induced hyperactivity in dorsal cingulate and bilateral amygdala. And then positive emotions, and then there was also hypoactivation to positive stimuli, again in vitreal striatum and posterior cingulate and also in dorsal cingulate. So one of the ways we've been looking at cognitive processing in our lab is to combine domains. So combining the domain, for instance, of attention and emotion processing in an affective type of dot probe task. So in a dot probe task, and in our specific affective dot probe task, patients see two faces on the screen. And one is either angry or happy or neutral, and the other one is always neutral. And of course, which side they appear on is randomized. And after seeing that for a brief period of time, one of the faces will be replaced with a single dot, and the subject's job is to just respond whether that dot appears on the left or the right. If the dot appears behind the neutral face, we call it an incongruent trial, and if the dot appears behind the emotional face, we call it a congruent trial. And we have some interspersed faces that are upside down just to add a little more cognitive load in the emotional processing. And then we also have control trials where both subjects are neutral. And when we looked at that task and treatment with ketamine, we found some interesting results in dorsal cingulate. And I should also mention that part of this task was a mixed block and event-related design. So we had blocks of angry faces where it was always angry and neutral or neutral and neutral. And then we had blocks where it was always happy and neutral or neutral and neutral. So we see this group by emotion by drug interaction in these subjects in their response to individual events within a block. So under the placebo condition, the healthy controls actually activated more to the angry faces and less to the happy faces, while the depressed subjects under placebo did the exact opposite. However, under ketamine, that reversed, such that after treatment with ketamine, our depressed subjects looked a lot more like our healthy subjects under placebo, and our healthy subjects under ketamine looked a lot more like our depressed subjects under placebo. So this is consistent with that idea that we see ketamine increasing depressive symptoms in our healthy subjects, but decreasing them in our depressed subjects. Another thing we can look at with these tasks is association with subsequent response to ketamine. So there was a paper in 2013 looking at a different drug, scopolamine, that showed that bold response in a working memory task was correlated with activity within the middle occipital cortex. And this is a visual area, and it's also kind of related to the default mode. Many visual areas have large connections to the default mode network. And when we looked at that in our current study, we found that the bold response in the dot probe task was actually correlated quite nicely with the response to ketamine. So we do have some convergent findings that even drugs that are very different may actually be have downstream effects that are actually quite the same, at least in what their effects are on the brain. We're also developing some new tasks in our laboratory. We have an activity rating task where we show subjects pictures or words describing different activities, and we ask subjects to rate them, whether they strongly dislike them or strongly like them. And one thing behaviorally that we find is subjects with depression, particularly subjects with depression that have a high level of anhedonia, will actually describe far fewer of these activities as pleasurable than healthy subjects. And when we look at brain activation that varies parametrically from most disliked to most liked, we actually see robust activation in the posterior cingulate and in perihippocampal cortex areas, as well as in the insula. So we're getting into some areas that are related to that triple network model within a reward processing domain. And we're currently piloting this task in depressed subjects as well. We've also developed or modified a suicide implicit association task for use in the MRI scanner. So implicit association tasks involve categorizing words and involve two different groupings of words that are allowed to interact. So for example, in the suicide IAT, we're asking subjects to categorize death and life words and me and not me words. So the death and life words might be things like death, dying, life, birth, things like that. And then the me or not me words would be things like my, our, your, their. And what we find is that in healthy subjects are actually much faster to categorize words when they hit the same button for life words or me words than with death words and with death words with not me words. So if we switch that up and put death or me together and life or not me, most healthy controls are slower. So what that tells us is that there's an implicit association between life words and me words, or the concept of life and the concept of me. And what's been shown there was a study looking at this task in depressed subjects who were hospitalized, and they found that subjects who went on to have a suicide attempt in the subsequent 6 months had a much greater association of the me words with the death words implicitly. So this is a task that can kind of probe unconsciously how people associate these concepts. And when we looked at, we piloted this task in healthy control subjects, and the healthy control subjects saw in contrasting the death with me blocks versus the life with me blocks, our healthy subjects actually showed much greater activation in salience network regions as well as some central executive network regions, which indicates to us that they're having this extra cognitive processing load that's being required to categorize these incongruent conditions versus the more natural life with me association. And if anyone hasn't done one of these tasks, I highly recommend it. You can go to the Project Implicit website, and they actually have a version of the suicide IAT that you can do yourself, and it's interesting. So a quick recap from our cognitive and functional imaging. So there are differential responses to negative and positive stimuli in limbic regions in our 3 core network areas, and ketamine appears to reverse some neural biases at least, and that we can have some novel tasks that may uniquely assess symptom domains that haven't previously been looked at. So another potential marker is in intrinsic connectivity. So the way we do intrinsic connectivity studies or resting state studies is we basically put people in the scanner with no task. And so people end up doing lots of things. They end up planning, they end up thinking about their day, thinking about loved ones, daydreaming. And as you might imagine, the experience can be very different from someone who is depressed. If you do a Google image search on depression, you get images like this. So as you can imagine, if someone with serious depression is put in the scanner and allowed to have their mind wander, they might be having depressive ruminations, negative self-talk, maybe even suicidal ideation. So these states are probably very different for depressed individuals and healthy individuals. And indeed, first in 2007, this was the first resting state study in depressed subjects, looking at the default mode network between depressed and control subjects. And they found hyperconnectivity within the subgenual anterior cingulate and the thalamus compared to healthy subjects. And these regions are also regions that are hyperactive on PET scans. And particularly this finding of increased resting state connectivity in the subgenual anterior cingulate has been replicated in multiple meta-analyses. Also, several meta-analyses have been done looking at individual resting state networks, and in particular, it's interesting because some of these three networks here, of course, the central executive default mode and salience network are part of that triple network model. And what these meta-analyses have showed is that these networks are very interconnected. Our central executive network, for instance, when we look at depressed versus healthy controls, we see differences in salience network regions. When we look at the salience network, we see differences in default mode network node connectivity to those regions. So there's definitely some complex interactions going on. Other studies have looked more directly at this, looking at individual regions within each of these networks and looking at how they interact in depressed subjects and non-depressed subjects. But at this point, there hasn't been enough work in this, in particular looking at this triple network model in depression to form a scientific consensus yet. There have also been resting state studies in treatment of depression. So this was a study looking at the posterior and anterior subnetworks of the default mode, and they found that the connectivity in the posterior subnetwork of the default mode actually responds quite well to treatment, where you see a change in the connectivity such that post-treatment the depressed subjects and the healthy subjects are quite similar, whereas in the anterior subnetwork, treatment doesn't really actually seem to have much effect. So studies like this may help us gain a little bit of insight into why our treatments are not working and help us know if there are some aspects that one drug is treating that another isn't. So we've also done resting state, looked at the resting state in our mechanism of action study, and this is a complex slide, so I'm not going to talk about the whole thing, but basically, so this is just looking at group differences at each time point, and one of the more interesting findings was that at every time point, there were differences between the healthy and depressed groups in the bilateral insula, or in the salience network. And at day 2 following ketamine infusion, this difference was completely gone. And when we look at treatment effects, so this is looking at ketamine versus placebo at day 2 post-infusion and day 10 post-infusion. And in our depressed subjects, we see that in day 2, we see increased connectivity with the default mode network, again in the insula and within the posterior cingulate. And interestingly, at day 10, we see what appears to be a rebound effect, at least in the posterior areas, where connectivity is actually decreased in the ketamine versus placebo condition. So from intrinsic connectivity, has really, probably more than any other domain, has really started to point to some alterations in this triple network system. So finally, I'm going to talk a little bit about neurophysiology. So the two ways primarily that we study this are electroencephalography, or EEG, and magnetoencephalography, or MEG. So in EEG, most of the literature is focused on frontal asymmetry, particularly in the alpha band. So that's just looking at the alpha power on the right-hand side of the brain versus the alpha power on the left-hand side of the brain, and that's been found to be different in depression. There's also been some work in prediction of response to SSRIs, and looking at the response in the EEG, looking at 1 week after someone has begun treatment and being able to predict if the drug is going to be effective 6 weeks down the line when the full response is evident. And we can also look at this with magnetoencephalography, or MEG. There are far fewer studies looking at depression, and there really aren't enough for meta-analyses to show convergent results at this point. However, one nice thing about MEG is we can perform much more accurate source localization so that we can localize these electrophysiological effects to actual anatomic structures. So for instance, this was a paper by Brian Cornwell in 2008 looking at a face recognition task in healthy subjects, and he was able to localize, looking at emotional faces next to non-emotional faces, actually localized quite nicely to the amygdala. And a subsequent study looking at repeatedly presented emotional faces in depressed subjects showed that when you look at the amount of habituation that occurs in response to an emotional face, that habituation actually correlates quite nicely with the later response to ketamine also in the amygdala. So that's one of the strengths of MEG, is we can look at, we can actually look at electrophysiological activity, but combine it with looking at structures such as the amygdala and subgenual cingulate that we know to be involved in depression. There have also been some nice studies looking at acute changes in brain function with ketamine infusion. And in this study, the infusions were actually done in the MEG scanner, and so this is during the infusion. There are robust and widespread alterations in spectral power across all the bands, with delta, alpha, and beta showing decreases in power, and gamma and high gamma in particular showing increases in power. And in our mechanism of action study, we also included MEG, but it was done around 6 to 9 hours post-infusion, not acutely during the infusion. But even at that point, we still see increases in gamma in the ketamine condition compared to the placebo condition, and these localized to regions within the default mode network, and very nicely localized to areas within the central executive network. And this is just a few regions showing that both the healthy controls and the depressed subjects actually show robust increases in gamma power in response to ketamine. Interestingly, when we looked at the gamma power response and the MADRS response, or the antidepressant response, we found that the change in their depression rating scores was actually only associated with their gamma power in the healthy controls, in the thalamus and cuneus in particular. So if we just do some scatter plots here of the gamma power versus the change in MADRS post-infusion, we see this nice correlation in healthy controls, but not in the depressed subjects, which we found odd. But when we took subjects and divided them up based on their baseline gamma levels, we found a really interesting interaction. So that the subjects that started out with low baseline gamma, if they had a large increase in gamma power as a result of ketamine, they had a very nice antidepressant response. However, for the people that started out with a high baseline gamma, if they had a large gamma response to ketamine, they actually saw much worse response to ketamine, and in fact got a little bit worse. So this tends to indicate to us that there might actually be an inverse U-type curve here, where there's an ideal gamma power for each person, and being either having very high gamma or having very low gamma power might actually both induce some of the same pathologic symptoms. And that might also explain why our healthy subjects who are already at a relative homeostatic level of gamma, why ketamine would induce depressive symptoms in them. We've also looked at somatosensory tasks. This task involves just giving a brief air puff to the finger to activate the somatosensory cortex. And this is a previous study in 2012 where it was shown that ketamine actually potentiates the response in the somatosensory cortex, but only in the subjects who respond to ketamine. And we recently replicated this in our data, showing again that there was a large difference between ketamine and placebo, but only in the responders to ketamine. And then when we look at gamma power versus the percent change in MADRS score, we see a nice correlation here. We can also look at this task in terms of connectivity. So this is using a method called dynamic causal modeling, and an architecture looking at somatosensory cortex as well as frontal cortex. And what was found here was some nice correlations between NMDA parameter estimates between the left and right somatosensory cortex and the response to ketamine. And then the feed forward on the feed forward connection from somatosensory cortex to frontal cortex, the AMPA parameter was correlated with the response to depression. And finally, we can look at multimodal analysis, which was really the fundamental topic of this talk, and part of what the point of the ketamine mechanism of action study is. And so we can start trying to combine multiple modalities and see if there are complex interactions between what we can learn from one modality and what we can learn from another modality. And we're still sifting through our data on this, but this is just an example of one finding we have so far, looking at a DTI metric that is just a single number that gives a measure of white matter integrity, such that a higher number implies worse white matter integrity or worse white matter health, and a lower number implies better white matter health. And what we see in the healthy controls is that there's a nice correlation between white matter integrity and gamma power in the left amygdala to subgenual anterior cingulate tracts. So for the gamma power here, we've just taken the gamma power in the amygdala and in the anterior cingulate cortex and averaged those together. But in our depressed subjects, this relationship was completely abolished. So these are the kind of interactions that we're looking at, and while we don't know the significance of this yet, it may be that we can find out more and be able to predict better who may respond and who may not respond by combining information from many modalities rather than just looking at one modality as has been traditionally done. So quickly recap, we found all of these different modalities that we've used, structural imaging, including volumetrics as well as DTI, cognitive functioning and functional imaging, intrinsic connectivity, neurophysiology, and then some of these multimodal imaging techniques. They all have tended to converge on the same things. We see we see a lot of alterations in our limbic area, so that would include the hippocampus and the amygdala. We see alterations in the tracts connecting those regions to the cortex and areas of the limbic cortex. And then we see a lot of abnormalities within these three networks in this overarching triple network model that we think may be involved in the pathophysiology of depression. So overall, I think that, as I said before, I think multimodal imaging is probably one of the ways that we can kind of harness this and develop a more full image of what actually causes depression. And this is not an exhaustive list, but just a list of some of the people that were involved in the imaging results that have been presented here. And thank you very much. Questions? So the question was whether there have been reliability studies in resting state data. That's a very good question. We have looked at, not with fMRI, but we've looked at the reliability of some of our resting state MEG methods within sessions, so when we had multiple recordings taken within a session. I don't know the resting state fMRI reliability literature that well, but I would say that overall, in general, in the neuroimaging literature, there's not nearly enough reliability analyses performed. All right, thank you.